Thank you for joining us today for this module with Dave Crotwell, who will be discussing operational issues that in some cases are unique to children's hospitals. Dave, would you take a minute and tell the viewers about your background?
Yeah, hi, thank you for having me, Gary. My name is Dave Crotwell. I am a respiratory therapist by trade. I also have the registered respiratory therapy neonatal pediatric specialty credential, and I'm a fellow in the American Association for Respiratory Care. I have about 26 years of experience in respiratory care, and also outside of my RT credentialing, I have a bachelor's in management and a master's in healthcare leadership. So I've been in the leadership world for about 15 years now, and currently work at a tertiary children's hospital in the Pacific Northwest.
So also we've got the expert for children's healthcare services. Well, we're going to talk about productivity and reimbursement, and we know that they're intertwined in many cases, but a lot of folks get them confused. So let's start off with productivity. Let's start off with a high-level discussion for those RTs that don't work in children's hospitals. Again, most of us work in adult care. And I think what you and I have talked about through the years is sometimes it's the same, sometimes it's different. So can you provide a brief history of how children's hospitals are reimbursed, about productivity, and any changes that you foresee?
Yeah, so when I think of reimbursement and productivity, I tend to separate them out because they are really two separate issues. And there, historically there was this thinking that children's hospitals and pediatric facilities they don't really care about productivity because they have a bottomless pit of cash to pay for everything. But that is definitely not the case anymore, or in some cases hasn't been at all for some children's hospitals. And so we're in a transition period when it comes to reimbursement. Productivity, I wish we had a standardized method for measuring productivity across all respiratory care services, but we don't. Within my organization, we measure productivity in a couple different ways. We one, prospectively look at estimated productivity needs or demand to right size the resource to the demand for any given shift, so that then we're set up for success and already set up for this idea that we can be productive. And then secondly, we have attached productivity metrics, or RVUs, or minutes of RT work, to every therapy or procedure that we perform. And in some of those cases, they have been standardized through the Uniform Reporting Manual, and we've just accepted the AARC's RVUs, or in some cases, we have done time measurements and created our own for children's and pediatric patients. But we take those RVUs and then we use them to make staffing decisions on the front end and tell us how many people we need to meet the demand for that shift. And then on the back end, we tabulate those RVUs based off of completed either statistical or revenue or non-revenue generating or revenue generating charge codes. And we tabulate those minutes of work on the back end. And that tells us how much work we actually completed. And so we use that to make sure that we're being fiscally responsible and good stewards of our resource, so that we're using actual data to tell us this is the demand, this is the resource we're going to put at that demand, and then on the back end, this is how much work we completed with that resource, so that finance can feel like we are being good stewards of that resource. When it comes to reimbursement, that has been something that's been changing over the years. And I know that in the adult world, in the adult arena, with HMOs in the 80s and early 90s and Medicare reform, there was this push to be very efficient with your resource and really kind of make sure that you're tracking every little therapy or task that you're performing. In those cases, the billing changed as well, and you were pushed into this DRG based reimbursement or cost per case, and Medicare, was pretty strict about their reimbursement methods. Within children's institutions, we have a very different payer mix. We have a mix of state Medicaid, Medicare, and private pay insurance, and they all want to reimburse for care performed differently. And Medicare is very similar to the adult world when it comes to reimbursement. We just have they make up a very small percentage of our payer mix. State Medicaid is probably the next largest. And then after that is private pay insurance. And to break it out even further, each private pay insurance provider may want a different contract associated with reimbursement. And so historically, these children's hospitals and pediatric facilities, basically, we had RT charges. We would bill for those RT charges as an individual charge on the patient's bill, and they would reimburse based off of the contract that we have negotiated and pay a percent of those charges. What we're seeing now is a trend towards pushback from payers to pay for RT completed work. And that's come in many forms. One of the forms that we're seeing is they just nickel and dime all the charges to the point where you basically say, okay, we can't spend any more hours going through these charges with you. So just give us, X amount of dollars and we'll write off the rest of the charges. And then in some cases, some payers are saying, we don't want to pay for RT services as an individual bill at all. We want that to be bundled into the hospital bed or bundled into a procedure that the RT did the work during. So the third payer essentially in some cases is saying, we don't want to pay for RT services because we feel that this is nursing care. And in most cases, nurses are performing these therapies or doing this work, which is, like we know, in most cases, not the case. It is generally RT work that's being done by respiratory therapists.
Yeah, makes sense. Hey, you meant a lot of us don't work in a bundled payment methodology, or we may have a different definition of what bundling is. You mentioned that. Can you expand on that, please?
Yeah, so the payer pushback that we've received over the years for individual RT charges on a hospital bill. And when I refer to that, I mean a bill for every chest physiotherapy treatment, a bill for a daily charge on the hospital bill for mechanical ventilation, a daily charge for non-invasive ventilation or a therapy, high flow nasal cannula, et cetera. The pushback that we have received over time and the request has essentially pushed us into what we refer to as bundling of charges in our world, where we have basically said, okay, well, you don't want to pay for the individual charge. The work still needs to be completed. And so we bundle our charge into the hospital bed daily charge. So it's essentially paying for the RT service the same way they would be paying for nursing care as part of the daily bed charge.
You also mentioned that payers are pushing back on reimbursing for respiratory services. Is that a matter they think they're not appropriate, they're not clinically validated, or that others can do them? And you mentioned, should that be included by nurses to provide as part of the room and board? Can you explain if there's a little bit further about that?
Well, the interactions that we've had with payers that believe that nursing care encompasses vent management and all these other therapies that respiratory therapists traditionally and normally provide in the United States as our expertise. In some cases, they don't really give a reason why they feel this is nursing care and not respiratory therapy care that should be done by a respiratory therapist. They just essentially throw out, we believe, or it's our policy that this is nursing care. And my opinion is it's an excuse to just not have to pay for the care. But that's my opinion. Because I have yet to get a valid answer for why they believe this is not respiratory therapy care as opposed to nursing care.
Dave, you mentioned about the transition with children's hospitals from the world of fee-for-service to capitation, bundling, and other. In the adult world, we've had to make those changes because of DRG and capitation. Can you talk a little bit about that, where children's hospitals are today and where you think they're heading?
You know, the transition period that we're in within pediatric respiratory care right now, and that is transitioning us from the fee-for-service world for reimbursement to the adult models for reimbursement, is changing the way we have to think, and in some cases manage our resources within the institution. And what we have seen, at least in the states like mine, where we have a lot of payer pushback and we're no longer the revenue generator that we used to be, and we are now transitioning to more of a cost center, that we need more than ever to be able to track our productivity so that we can justify the resource, with the realization that it's easier in many cases, especially with hospital administrators, to justify a resource when there is revenue associated with that resource. But when you start transitioning away from fee-for-service and billing for individual RT therapies or services, it's much more difficult to tease out that financial benefit of having a skilled respiratory therapist perform the care. And so what it's really done to us is it's made it that much more important that we track the work we're doing. We make sure the work is evidence-based and we only do the work that's effective and that we should be doing. And that we use those productivity metrics to justify the resource, knowing that the chance moving forward of us being able to justify the resource through revenue generation, at least on the inpatient side, it may be different when you're talking about outpatient pulmonary diagnostics, but on the inpatient side, it's really going to move to how much work are you doing, what's the work, how does it add value to the patient in order to justify the resource.
That makes sense. That's helpful. Thanks, Dave. Let's talk about productivity. How do respiratory therapy departments at children's hospitals track their productivity?
That's another subject in which I wish we had a standard, because unfortunately we don't. At my institution, we have chosen to track productivity through RVUs, or completed minutes of RT work. And so we look at our cost and our cost per unit of service, and our unit of service is minutes of RT work. And so we have chosen to essentially tabulate all these minutes of RT work associated with completed therapies, and we use that completed work as a measure of productivity and reference it to our overall overhead spend or salary dollars. And there are some hospitals that are using census days. There are some hospitals that are using an adjusted patient day metric as their unit of service. Some are using, depending on the outpatient world and PFT, some people use completed number of tests. So there is no real standard. And I think that that's one of the problems, because in order to effectively assess your productivity, you have to be looking at the right metric. And in my eyes, the right metric is RT work and or specific RT interactions with patients. And so at my institution, one of the things that we've done, it's not our primary metric, but we also track what we refer to, or I refer to, as RT patient days, which is the number of patients on any given day in which RT is interacting with or providing care to. So we're not looking just at the overall daily census and using that as a unit of service or as a metric. We're looking at the census in which we are interacting with and providing care to. And the reason I did that is because what we were seeing historically at my institution was census days were not increasing, but RVUs and RT work we saw were increasing dramatically in 1 year by 37%. And what we found when we looked at it is when you evaluate multiple metrics like census days, RV respiratory completed RVUs, even case mix index or acuity metrics, what we found was we were treating 22% more of the daily hospital census in 1 year than we did the previous year. And that's why I created this RT patient day metric to track, because then that really tells you over time how many RT patients and how much they're increasing year over year or over time. And so that's, how we, kind of in a nutshell, the way we measure productivity is looking at a combination of RT patient days, completed minutes of RT work, and then our overall cost per unit of service or cost per RVU. If that makes sense.
Makes a lot of sense. In fact, I hadn't thought about RT patient days, but that makes all the sense in the world, because that's the folks that we care for, whether children's hospital or adult world. You have to take that into consideration for working with adult patients and adult clients.
And I developed, Gary, I did, just to kind of let you know how I developed that. I developed that after a conversation with our CEO, in which he was telling me, well, I don't see why you need more staff because your work has not increased. And I said, yes, it has. And he said, no, it hasn't. And I said, why do you say no, it hasn't? He says, well, census days hasn't gone up. And I said, well, census days is not a good reflection of RT work. You have to look at the work that RT is performing with each patient and the patients that RT is seeing. And so when you actually track RT work, which is completed therapies or patients requiring respiratory support or any other procedure that we provide, and then you look at the percent of the daily hospital census that we are taking care of, that's really the trend that we should be looking at to make decisions about growth and the need for RT resources, not looking at census days.
Yeah, it makes sense to me. It's almost mind-numbing, the productivity metrics that folks espouse. And I think some like to have a one-size-fits-all, which would be ideal, but just isn't, it's not the reality. Hey, you mentioned something about not having a standard productivity system. Do children's hospitals as a whole have a standard productivity system, and do they benchmark against each other?
So there's two answers to that. One, no, there's no standard productivity system across all children's hospitals. I wish there were. Unfortunately, there are a lot of differences in the way children's hospitals function. There are children's hospitals in which RTs only work in the ICUs and don't work outside into the acute care arena at all. There are children's hospitals in which RTs work everywhere and perform every single therapy that has the term respiratory or involves the pulmonary system. And then there's the hospitals that are in between, where they have some shared tasks with nursing, but then they provide the care to the patients that they believe respiratory has the expertise and is the only provider that can do that service. So there is no standard. And what you will find is the trend towards the majority of children's hospitals now are at least tabulating completed work, whether that be in procedure counts or RVUs. And they're using that to help inform their decision related to how productive they are. So most children's hospitals quite a few children's hospitals in the US, I think there's upwards of 55 or so, are members of the Children's Hospital Association. And the Children's Hospital Association has benchmarking capabilities and benchmarks children's hospitals' efficiency, cost effectiveness, and provides that benchmarking information to each institution to compare and each other to like institutions. And they call that, within the Children's Hospital Association, the prospect. And the prospect data, what they've done, and it's changed over time, It used to be called PACT, where they looked at all completed minutes of work. We'd have to do this onerous tabulation of every minute of work, and it was just too manual. So what they've done is in order to automate it, is they've basically come together and said, okay, what are 5 or so common procedures or therapies or life support that all children's hospitals provide? Because what we're finding before is, oh, one hospital, Hospital X, was still doing oxygen rounds and incentive spirometry and having RTs do that work and counting that as a procedure and the minutes of work associated with it. And then Hospital Y was no longer charging for oxygen, not doing oxygen rounds, and not doing incentive spirometry, and it passed that on to other providers. And so it was hard to get apples to apples. And so they felt like the only way they could get apples to apples was by taking this and looking at, these are the numbers that we know every children's hospital provides, or the therapies that every children's hospital provides. And so what they do is they take the numbers or the volumes associated with those therapies, and then they reference them to other salary metrics, overall supply costs, worked hours, overtime, et cetera. And then we have these benchmarking metrics that are overall cost per unit of service, worked hours per unit of service, salary dollars per unit of service, and overtime. And then they essentially compare all those hospitals in the CHA that have reported together and as a benchmark. And you can look at it and say, my institution is at the X percentile, the 50th percentile for salary dollars per unit of service. And what some hospitals are doing is they're taking that data, and then they're using that as one of the metrics. Unfortunately, there are some hospitals that are using that as the only metric, and so they're limiting RT resource based off of this data. And like every data set, there are some flaws associated with them. They're not 100, they don't 100% tell the story. And so it is a shame when there are institutions that are withholding FTE and posting positions associated with data that may or may not be as accurate as it needs to be. But I believe it is a tool that you can use along with your own internal productivity metrics to assess how well you are performing compared to your peer institutions.
Since it's kind of a way to triangulate, given what you do internally in your organization, and to have that, it's probably not a bad idea to have another data set, may point you in a direction. Well, while we're focusing on clinical productivity, 2 questions come to mind. Do you look at the cost to produce a procedure or service? And I think you touched on this a bit, but maybe amplify it. And secondly, how does this enter into the formula to decide upon a particular procedure or service?
Yes, we do. And there's 2 ways that we look at it. There's one, we as a teaching institution, we get physicians that come to our institution from all over the country. We recruit new physicians as we've experienced growth, and they have different experiences. So they come to us and say, well, at Children's of XYZ, we do this therapy and you don't, and I feel like we should start doing this therapy. Well, what we do when we experience that is we then do a lit review. We look at, is there any evidence to support this therapy is better than what we're currently doing for that patient? What are the risks? What's the benefit? Capital costs, et cetera. And then we decide whether we feel like we want to add that therapy to our arsenal. Because what we've seen over the years when it comes to some of these therapies, and this is where the real cost and where the rubber hits the road, or the real cost is for respiratory labor, is the utilization of RT resources and the number of treatments and therapies that are offered and provided. And what we're seeing with some of these complex patients is this layering of therapies. So patients that used to get incentive spirometry may get chest physiotherapy for prevention of atelectasis, even though there's no data, very limited to no data to support that as a therapy that benefits or reduces the risk of developing atelectasis. May increase depending on the patient population. And so we are looking at this layered approach where they're saying chest PT. Now, oh, they have ineffective cough, so let's add cough assist. And oh, well, at children's of XYZ, they did IPV, so let's add IPV on top of that. And next thing you know, you're spending all day with one patient, and your labor and you can't hire RTs fast enough. And so that's why we look at through this lens of what are we providing, what's this national kind of standard of care for providing a specific therapy for like airway clearance or inhaled medications. And then whenever someone wants to introduce something new, we do this assessment of risk benefit and cost benefit, and then is there evidence to support it. And then there's this is how we've always done it, and maybe we should look at doing it differently. And we did that years ago when we transitioned to primarily a meter dose inhaler with valve holding chamber method of delivering bronchodilators to our pediatric patients, where we were looking at the amount of time RTs were spending at the bedside, the cost of, when you look at actual labor dollars, cost of supplies, and cost of medication, and not just one of those areas, you then can start doing this cost analysis of this is how much it really costs to deliver an MDI with a valve holding chamber. If we pay $16 for the MDI, X number of dollars for the valve holding chamber, and we spend 8 minutes at the bedside, and as opposed to in pediatrics, where I don't believe anyone should be doing concurrent therapy, but in pediatrics you really can't do it because of the patient population. But the spending 20-25 minutes or at the bedside to give every nebulizer treatment, and the effectiveness of the overall medication delivery. And so we do take all that into consideration when we're looking at it. And one of those things is what's the cost, not just the supply costs, but the labor costs. And then what's the cost associated with overutilization of therapies? That's where and we've talked about this previously, but that's where we really, as we move forward, need to look at the meat and potatoes of cost savings within healthcare. Is how do we do the right therapy to the right patient at the right time, being done by the right provider, and we make sure that therapy is backed by evidence. And so, to make a long story short, yes, we do look at the cost, not only the cost in dollars, but the cost in risk, the cost in time, and supplies, and do this benefit analysis with each therapy that we provide.
So what you just said, Dave, should be emblazoned and etched in stone, or whatever we're going to call it, and given to every administrative resident and every fellow or resident intern, because that's it. There's no value in saving on the cost of a device if the service shouldn't be provided in the first place.
And the reason, I'll get off the soapbox, but the reason why this is not the standard, and why people allow the essential drift and expansion of care utilization, is it's difficult work. Right. Is that it requires sometimes conflict, and it requires sometimes discussions. And in pediatric institutions, historically, we have not been good at those discussions, because no one wants to put the cost of care and of caring for a child. So, it's very difficult when it's not easy with anyone, but when you're talking about, well, we shouldn't do that because it costs too much and there's no evidence to support it. And then people immediately go to, well, how can you put a dollar amount on this child's life, or what this child's condition is? And it's not that. It's really like none of the therapies that we provide are completely benign, and we really need to look at it and at the fact that we're doing the right therapy to the right patient, and we have evidence to support it. But we also just need to get medical leadership to back us and to help us and support us in this endeavor to reduce overutilization of care. It can't just be pushed out from the RT service or the radiology service or lab service. We have to have medical leadership to be successful.
Now, you ended on a statement that gives me an idea for the next question, Dave, is who in your institution is influential in determining, developing, managing productivity targets and measurements? Who are some of those folks? Who's kind of like the top five who's influential in that?
So that has changed over time, and I've inserted myself more into the process. A long time ago, it was when I talked to you about the fact that they were using census days as our primary metric for work, they would say, we're going to see X% increase in hospital census days for next year. And then they would try to apply blanketly a percent increase to RT work. But primarily, at least in my experience, it's the director of RT or manager working with finance under the umbrella of their superior, which may be a VP or chief nursing officer or associate chief nurse. And then also using information from nursing leadership and physician leadership about trends in therapies or number of beds, expansion. And then, but it's essentially finance, sometimes strategic planning, administration, whatever that may be at your institution, physician and nursing leaders, and the RT team that is really overall looking at productivity, projecting or trying to help project the growth and work and need for RT resources, and then coming to some agreement about what you feel you need. And that is a moving target. At my institution, this whole idea that this is the resource you have for fiscal year 2021 is, to me, is ridiculous. Is you really have to have a commitment that you're going to right size the resource to the work. And so for me, and my mentality is really about, this is my starting point. And then it's a moving target. Every month, we do a position control chart with an analysis of the average amount of RTs per shift we've needed to do the work that's in our system. And one month that might be 22 RTs per shift. The next month it might be 18. And we do that, and we look at our roster and say, this is how many RTs I need to put this many RTs on each shift to do what is our average demand. And then also working into that, what's your percent turnover rate, so that you don't get behind, because this idea that short staffing RT, unless you're going to say that you're not going to provide the therapies, or you're just going to accept delays in care, it's going to cost you more money in the long run, because then what you get is contract labor, you get incentive shifts, double time, time and a half, double time. Some hospitals are doing double time plus 10 during viral season because they don't want to right size their roster and figure out ingenious ways of flexible staffing during the slower months. And so it's really a team approach, but you have to have kind of an RT leadership team that's very proactive, and you have to commit to your finance and strategic planning and administrators that you're going to be a good steward of the resource, so that then they give you the ability to actually manage the resource, if that answers your question.
It does. And Dave, that's a book of knowledge that, again, every administrator and physician, respiratory therapist should have. I think you hit on a couple of things. It's important to do the right thing in the right way by the right provider. And I think that simple concept is not either understood or communicated, or we wouldn't be in some of the situations you described where you were asked to achieve a certain amount of patient care services, but the resources are limited. And then we jump into premium pay. Kind of to summarize this, we talked about productivity, and we talked about practicing according to evidence-based care. The last area, kind of open-ended, is certainly these are important. We need to be efficient. I don't think anyone can argue with that. We need to track our costs of our services. We've heard the term value proposition, and it may be overused, but I'd like to kind of close on that. How would you define the value proposition for your services in children's hospitals?
This is a topic that there's probably quite a few people in our field that may disagree with me. And I know that we've discussed this historically, but I really feel like historically within the respiratory care world, there has been too much focus on who's doing the task, how many tasks can we do? If we don't do this many tasks, we're not justifying our existence. And I would argue that tasks are not the value that RT brings to the bedside and the care that we're providing. And if we really take, if we really look at the holistic approach to care and the big picture and the overall cost of a hospital stay and how RT contributes to that and provides value, I believe that's where our focus needs to be moving forward. And by what I mean by how do we provide value? Well, when are there times throughout the continuum of a patient's care in which when you insert the expertise of a respiratory therapist to evaluate and treat, or maybe just evaluate, and even if you're in an institution where someone else is doing the treat, the respiratory therapist is doing the evaluation based off of their expertise. And how does that insertion of that resource improve outcomes, reduce hospital length of stay, reduce risk of infection, et cetera, and really looking at the value that RT provides throughout the continuum of care of a specific patient, and not focus so much on the individual MDI treatments, inhaled nebulizer treatments. Because the reality is my RTs at my institution aren't providing value by squirting medicine into a cup and turning a flow meter on to 6-7 liters per minute. They're providing value by coming to the bedside of a patient that has a known or unknown pathophysiology or disease, doing a cardiopulmonary or respiratory assessment of that patient and evaluating their respiratory status and helping, if not maybe deciding and maybe working with physicians or providers to decide what the best approach to care is for that patient. And so really when you look at it, it's really transitioning this idea of, of how many treatments did I do to, did I do the right treatment to the right patient that will then improve outcomes or reduce length of stay? Because the only way in healthcare we're really going to make a dent in the cost of care is by keeping patients out of the hospital, or getting them out of the hospital sooner, or reducing the risk while they're in the hospital so they don't get a secondary either infection or something that will keep them in the hospital longer. So to make a long story short, I know I've kind of gone around, but we really have to change our idea of the value that respiratory provides at the bedside. Because when you think of our colleagues in the nursing world, the value of a nurse is not, they can push that medication, they can dress that wound. It's the all-encompassing skill and expertise that nurse provides to that patient throughout their day. And that's how we have to look at respiratory care moving forward. And we're going to be pushed into that, I think. And we have to realize that there are some things that some tasks that someday down the road we may decide we should give up. But what we shouldn't give up is the value that the skill of a respiratory therapist brings to the bedside when it comes to assessment, treatment, and evaluation of effectiveness of therapy.
Dave, I think, again, you wrote a chapter in a textbook that we should all be reading, and that is busyness should never be conflated with effectiveness. And for a lot of us, for a lot of years, it was counting the widgets, nebs done, successful ABGs drawn, and not really looked at, should we have done it in the first place? Or even if it wasn't appropriate, when that patient was admitted on a Monday and needs Q4-hour breathing treatments, why are they leaving on Thursday and Friday, or Friday, getting the same frequency of breathing treatments? That just doesn't make intuitive sense. So I think you nailed it, Dave. And it's a pivot our profession or organization, I would hope, the whole healthcare system would consider in order to get the right care to the right people in a way that we can afford it.
And I think that, one last thing, I think that when it comes to the care of respiratory patients, I think that the only way that we are going to, and the benefit that respiratory therapy provides is that ability to evaluate effectiveness of therapy. There's the initial, this is what the evidence supports. And in pediatrics, in some cases, there's limited evidence. So in many ways, in pediatrics, we have to take the approach of, unless we know it's dangerous, is not withholding care, but doing an attempt at care and evaluating the effectiveness of that care. If it works and is effective, continue at the appropriate frequency and titrate that frequency as the patient moves through the continuum. If it doesn't work, then stop it. And that's where the RT is going to provide the benefit. And that's where the institution is going to see the cost benefit of having respiratory therapy, because they will be able to reduce that overutilization of care and still keep the patient safe and make sure that they're still getting the therapies they need.
Dave, I couldn't agree more. When your book comes out, please make sure that I get the first copy, because that truly is the theme that we need to convince all those stakeholders within the hospital, certainly even the government payers, that the value is not in the busyness, in the doing, is it nebs per shift, but rather assessing a patient and make changes in their care plan. So I get enough, Dave.
You and I have talked about this as well. It's just also in the terminology that we use. I'm, as an RT, I don't do a vent check. I do a patient ventilator assessment. I'm not just there. Anyone, the electronic health record now can document the numbers automatically. So I'm evaluating the ventilator, the patient, and their interaction. And that's the benefit that an RT provides, not going to the bedside and documenting 50 different numbers and to say that we've done a vent check. So,
yeah, good point. Well, I can't thank enough, Dave, for providing this insight on the operation and priorities of children's hospitals, and particularly since most respiratory therapists work in the adult acute care environment. This has really been informative. So I can't thank you enough, Dave. Thank you.
Thank you, Gary. I appreciate you having me.